What do I do if my patient develops tachycardia in the hospital settings is the topic of today's video. Let's start. The formal definition of tachycardia is heart rate more than 100, but on the floor we often get notified when the heart rate is above 120 and is sustained or recurrent, not just for sporadic episodes. When I get notified, the single most important question I ask is the patient symptomatic or not? And what are the rest of the vital signs? The answer to this question will dictate the next step in management. Patients with symptoms or unstable vital signs due to tachyarrhythmias require emergent intervention. Leave everything and see them immediately. Unstable vital signs and symptoms due to tachyarrhythmias, whether wide complex tachycardia or narrow complex tachycardia, necessitate immediate synchronized cardioversion. The exception to this is sinus tachycardia, which is where we need to treat the underlying cause instead. If the rhythm is too fast to tell if it's sinus tachycardia or not, just proceed with synchronized cardioversion. Tachycardia-induced signs and or symptoms happen when tachycardia is severe enough, typically above 150 to 160. The fast heart rate leads to shorter filling time, which consequently leads to decreased cardiac output, and subsequently this will lead to hypotension, which causes symptoms like chest pain, shortness of breath, altered mental status. Remember that palpitation alone is not a sign of hypoperfusion and do not warrant cardioversion. For synchronized cardioversion, get the crash cart in the room, put pads on the patient's chest, monitor vital signs closely every 2 to 3 minutes, sedate your patient, sync the machine with the patient rhythm, and then deliver a shock of 200 joules. This will often reset the patient's rhythm back to normal sinus rhythm. If you are not comfortable performing cardioversion, call for help from cardiology or your colleagues. But remember, you don't need a cardiologist to perform this emergent cardioversion procedure. You can run your plan by them. If they are available, great. But otherwise, please proceed with cardioversion and save your patient's life. You don't need to worry about anticoagulation here if the underlying rhythm is AFib or a flutter. You can anticoagulate them once they become stable. Don't worry whether it is narrow complex or wide complex tachycardia as well. It's an emergency. We need to save the patient's life. IV fluid resuscitation must be provided simultaneously if hypotension is present, as long as there is no active pulmonary edema, and again, regardless of the underlying rhythm. Once the patient is stable, it's time to identify the rhythm to try to treat and prevent further tachyarrhythmias. And here we follow the steps that we use with asymptomatic stable patients. And this brings me to the asymptomatic stable tachyarrhythmias. But before we continue, if you would like to receive a summary of this video, please subscribe to my Substack page. The link is provided below. Let's move to the stable patient. These patients have no tachycardia related symptoms and have stable vital signs. Obtain a stat-12 lead EKG and review the telemetry information to identify the underlying rhythm to help decide the best next step in management. If the patient was not on telemetry, please place them on telemetry immediately. Please don't just rely on the telemonitor. Always obtain a 12 lead EKG. Tachyarrhythmias can be classified into regular narrow complex tachycardia, irregular narrow complex tachycardia, regular wide complex tachycardia, and irregular wide complex tachycardia. Sinus tachycardia, AVNRT, SVT, orthodromic AVRT, and atrial flutter with 2 to 1 blocks are examples of regular narrow complex tachycardia. Atrial fibrillation, multi-atrial tachycardia, and atrial flutter with a variable block are examples of irregular narrow complex tachycardia. Ventricular tachycardia and any irregular supraventricular rhythm with an underlying cause of wide QRS like a bundle branch block, WPW, and pace rhythm are examples of regular wide complex tachycardia. On the other hand, atrial fibrillation, atrial flutter, MAT with an underlying cause of wide complex like bundle branch block, as we said, WPW pace rhythm, will cause irregular wide complex tachycardia. A very fast rhythm makes it difficult to detect any irregularity. In such a case, we must slow the ventricular rate to unmask any irregularity. Bagel maneuvers or adenosine can be used to slow the ventricular rate. More on this soon. So look at this rhythm here. It's too fast to tell if it's regular or irregular. And this is the rhythm after we slowed it down with adenosine. Adenosine is safe in all kind of narrow complex and wide complex tachycardia except the irregular wide complex tachycardia. Atrial fibrillation with WPW causes an irregular wide complex tachycardia and typically presents with a very rapid rate, polymorphic QRS, and some very short R to R intervals. This is the only contraindication to use adenosine and other AV blocking agents as well as amiodarone. I will not go over the characteristics of each rhythm in this video. I assume you know that. But remember the following, please. Most sinus tachycardias are in the range of 120 to 140. Most SVTs are in the range of 180 to 220. Atrial flutter is 140 to 160, so whenever the heart rate remains around 150, this is likely an atrial flutter with a 2 to 1 block. Atrial fibrillation typically ranges between 110 to 180 heart rate. Irregular, remember this, irregular wide complex tachycardia with a rate more than 200 raises the suspicion of atrial fibrillation with WPW. Wide complex tachycardia is VT, ventricular tachycardia, until proven otherwise. For ventricular tachycardia, heart rate must exceed 120 to 130. Let's move to the management part. Sinus tachycardia and MAT, multi-atrial tachycardia, are treated by treating the underlying problem. So sinus tachycardia is often a physiologic response to an underlying problem like pain, fever, hypoxia, dehydration, anemia, anxiety, withdrawals. So please don't try to slow this physiologic ventricular rhythm or physiologic tachycardia. Instead, treat the underlying cause. Now, inappropriate sinus tachycardia is a form of sinus tachycardia without an apparent cause, and there is something called postural sinus tachycardia, which again, from its name, the patient develops postural induced sinus tachycardia. These two entities are exceptions because there is no clear underlying cause. There is no emergency here, I refer them to cardiology, again for outpatient follow-up or inpatient consultation. Now, multi-atrial tachycardia is often due to pulmonary disease and critically ill patients with severe multi-organ disease. Again, treat the underlying cause. Now, for all the rest of regular and irregular neurocomplex and wide complex tachycardia, we need medication to slow the ventricular rate. Let's talk about neurocomplex tachycardia first. If the rhythm is suspected to be SVT, regardless what's the underlying mechanism of SVT, the rate is typically 150 and often above 170. Vagal maneuvers or adenosines are effective in terminating SVT. Vagal maneuvers that are used in clinical practice are carotid massage and Valsalva maneuver. Carotid massage, to be effective, should be performed on the right side of the jaw angle. Firmly rub the carotid for 3 to 5 seconds. If there is no response, repeat on the other side. Avoid carotid massage if bruit is present. Now, Valsalva, have the patient supine and forcibly exhale against a closed glottis as if they're trying to go to the bathroom for up to 15 seconds at a time. Now, adenosine can be used as an initial therapy or if the vagal maneuver fails to terminate the SVT. We push 6 mg IV. If no response within 1 to 2 minutes, push another dose of 12 mg. And if no response, give a third dose of 18 mg. Now, please remember the following about adenosine. For central line administration, cut down doses by 50% compared to peripheral line, which it means the initial dose will be 3 mg, then 6, then 9 instead of 6, 12, 18. For heart transplant patients, initial dose should be reduced to only 1 mg and may increase subsequent doses up to 3 mg if needed. And here I recommend consulting with the transplant team first if no emergency. The patient should be closely monitored when we push adenosine. The crash cart should be in the room. The pads are on the patient's chest. And please warn the patient they may feel they're gonna faint or they are fainting for a few seconds. Please do not panic when the patient goes into a brief systole on the monitor. That's what adenosine does. Adenosine is contraindicated in asthma and other bronchospastic diseases. And as a side note, they may trick you in the board exam with an asthmatic patient who needs a stress test, for example, and they will throw there the adenosine stress test. Please do not pick that answer. Now, if the rhythm is atrial fibrillation or flutter, for rate just 100 to 120, oral Metoprolol or Diltiazem instant release can be tried unless the patient is NPO. Now for rate above 120, IV Metoprolol 5 mg or 2.5 mg or 5 mg or Diltiazem 20 mg IV push can be tried. If no response within 15 to 20 minutes, a second dose of Metoprolol 5 mg or Diltiazem, this time 25 mg, we can try that. Now Diltiazem drip or Ismolol drip should be considered after the second dose if inadequate response. Loading with digoxin can be tried if the blood pressure is soft or there is inadequate response, particularly in patients with heart failure with reduced ejection fraction. Amiodarone bolus and drip is a good option if no response to the previous measures or if the blood pressure is too soft to start Metoprolol or Diltiazem or in critically ill patients. Please don't forget to correct any volume depletion, otherwise hypotension will develop quickly once we give this medication and the rate will be hard to control. Remember that Diltiazem should be avoided in heart failure with reduced ejection fraction. The proper dosing of Diltiazem is 0.25 mg per kg for the first dose and the second dose 0.35 mg per kg, and this will be roughly 20 mg for the first dose and 25 mg for the second dose. Quite often in clinical practice, the Diltiazem is underdosed, leading to suboptimal response. Digoxin requires a loading dose of 0.25 to 0.5 mg oral or IV, followed by another 0.25 mg oral or IV every 6 hours to a maximum of 1.5 mg over 24 hours. Check digoxin level 6 hours after the last dose. Cut the dose by 50% in patients with renal failure and creatinine clearance less than 15 ml per minute. Ismolol is very short acting and is used as a bolus of 500 mcg followed by a continuous infusion of 50 mcg per kg per minute. You don't need to memorize this. You can look it up or ask your pharmacist. Amiodarone bolus and drip protocol involves giving a bolus of 150 mg over 10 to 30 minutes, followed by a continuous infusion of 1 mg per hour for 6 hours, then 0.5 mg for the next 18 hours. It has the potential, amiodarone, to convert atrial fib or flutter to sinus rhythm. Amiodarone bolus causes less hypotensive effect compared to Metoprolol and Diltiazem. Let's move to wide complex tachycardia. Among all the wide complex tachycardia, we must identify this rhythm. Irregular wide complex tachycardia with a rate above 200 raises the suspicion of atrial fibrillation with WPW. If irregular wide complex tachycardia is suspected, avoid all the AV blocking agents and amiodarone. Here, procainamide is the drug of choice for irregular wide complex tachycardia. Procainamide, again, loading dose 20 to 50 mg per minute until a maximum dose of 17 mg per kg is administered, or arrhythmia is controlled, or hypotension occurs, then we stop procainamide. Ibutilide is a second line if procainamide cannot be used or inadequate response. For the irregular wide complex tachycardia, it is safe to use AV blocking agents, including adenosine. If the regular wide complex tachycardia was a supraventricular rhythm, it will respond. If it's VT, it will mostly have no effect, although a small percentage of ventricular tachycardia may respond to adenosine and other AV blocking agents. Or we can just go straight, which I like, to the amiodarone bolus and drip protocol. So you noticed here that we don't necessarily need to know the exact rhythm for this underlying regular wide complex tachycardia to initiate the treatment. Now, some special cases, critically ill patients on vasopressors frequently develop tachyarrhythmias. If the blood pressure plummeted due to the tachyarrhythmias despite vasopressors, proceed with cardioversion. If blood pressure remains stable on vasopressors, amiodarone bolus and drip is the best choice in this case for atrial fibrillation and atrial flutter. For SVT, adenosine should be used. For patients who refuse cardioversion, resuscitate them with IV fluid if they are hypotensive and not having an active pulmonary edema, and we use adenosine for SVT and amiodarone bolus and drip for atrial fibrillation or atrial flutter or other wide complex tachycardia. Again, if it's irregular wide complex tachycardia, we need to use procainamide and possibly ibutilide. So how do we monitor these patients? Patients who underwent cardioversion should be transferred to ICU or IMC for a close follow-up. Anticoagulation should be started in patients with atrial fibrillation and atrial flutter after cardioversion. Consult cardiology if the patient is hemodynamically unstable with tachyarrhythmias, those with all wide complex tachycardia, and for resistant atrial fibrillation fibrillation, flutter, persistent or recurrent SVT. Patients who receive AV blocking agents may develop hypotension. Metoprolol, esmolol, diltiazem, and verapamil can all lead to hypotension, particularly if the patient is volume depleted. If hypotension develops, IV fluid resuscitation should be provided, except again in active pulmonary edema. We do not need to cardiover these patients here, as hypotension was iatrogenic from this medication. If IV fluid cannot be used, norepinephrine should be started or used. Amiodarone has less hypotensive effect than beta blocker and calcium channel blocker. Digoxin does not cause hypotension. Patients who respond to IV metoprolol or diltiazem bolus, what we do, we start oral metoprolol or diltiazem, whether instant release or extended release form. If the patient was already on this beta blocker or calcium channel blocker, we increase the dose. If the patient was placed on the IV diltiazem drip or esmolol drip, wean off the drip and transition into oral agents as soon as possible and as soon as the rate is adequately controlled. Start oral diltiazem or metoprolol and discontinue the drip within 1 to 2 hours after starting the oral agent. For example, for a patient on a diltiazem drip, let's say 5 mg per hour, using the conversion formula, I will start diltiazem extended release 180 mg daily, and I'll tell the nurse to switch off the drip 1 to 2 hours later. Now for the amiodarone drip, finish the 24 hours protocol and then transition into oral medications. Sometimes I keep the drip at 0.5 mg per hour longer than the 24-hour protocol until the patient is stable enough to transition into oral medications. We try to transition to the lowest dose possible of oral amiodarone, usually 200 mg POBID for 3 weeks, and arrange for cardiology outpatient follow-up if the patient was not seen by cardiology in-house. If they were seen, then I'll leave that decision to them to decide on. Now, if amiodarone drip was used for atrial fibrillation or flutter, I may try to transition into oral beta blocker or calcium channel blocker instead of oral amiodarone. Again, we individualize these cases. Remember, for procainamide, once the arrhythmia terminates, we seek an alternative agents for ongoing management. The use of procainamide for more than 12 to 24 hours is associated with significant toxicity like prolonged QTc and torsades de pointes, and they require very close monitoring by usually cardiology to be on board for that close monitoring. If digoxin was loaded, ensure to check digoxin level 6 hours after the last dose. Checking digoxin levels soon after giving the last dose will result in an artificially elevated digoxin level. Start oral maintenance dose if the level is therapeutic. The typical maintenance dose is 0.0625 mg to 0.25 mg once daily. In the end, if you found this video useful, please give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. And remember that you can get a summary of this video by subscribing to my Substack. The link is provided below. Thanks for watching, and I'll see you soon.